Good afternoon and welcome to the fifth Food for Thought lecture for the 2021 calendar year. This lecture has been a valued community tradition of Trinity University for more than 30 years now. Tonight's discussion is brought to you by Trinity University Alumni Relations and Development Division and the Office of Special Events. It's part of Trinity's commitment to lifelong learning. I'm Mary Stefl, Professor Emerita of the Healthcare Administration Graduate Program at Trinity University. I've been with the university since 1984, served many years as chair of the Department of Healthcare Administration, and for a while as dean of what was then the Division of Behavioral and Administrative Studies. Today, I spend some time with the Division of Development, working to keep healthcare administration alumni engaged with the program. Other than that, I serve on some community boards, Master Leadership Program, the Humane Society of San Antonio, and Project Quest. But you didn't come here to hear about me this evening because it's instead, it's my distinct pleasure to introduce tonight's speaker, a former student and now an accomplished epidemiologist, Dr. Casey Rondello from Trinity's class of 1992. Dr. Rondello serves as Clinical Associate Professor of Public Health and Emergency Management at Adelphi University in Garden City, New York, where he co-developed Long Island's first graduate program in emergency management in 2003. For almost 2 decades, Dr. Rondello has served as disaster epidemiologist with the U.S. Department of Health and Human Services National Disaster Medical System. That means he works with a multidisciplinary team that's deployed to provide emergency medical and public health services and support to regions of the country overwhelmed by disaster. In this capacity, Dr. Rondello collaborated with CDC's Division of Global Migration and Quarantine Network in developing an isolation contingency plan in response to the 2009 H1N1 influenza pandemic. Other notable deployments have included dispatch to the terror attacks on the World Trade Center, Hurricane Katrina, Hurricanes Gustav, Hannah, and Ike, 2008, the Great Tennessee Flood, 2010, Superstorm Sandy, 2012, and Hurricane Maria in 2017. In addition, Dr. Rondello has completed over a dozen volunteer medical public health service missions throughout the world, including West Africa, Central America, South America, and Asia. For his efforts, he's been awarded the U.S. Council on Service and Civic Participation's Gold Service Award and Adelphi University's Excellence in Faculty Service Award, one of the highest honors a faculty member can receive. After Trinity, Dr. Rondello went to Yale University School of Medicine, where he earned a Master of Public Health, and then later to St. George's Medical School in the United Kingdom, where he earned his MD degree. Pretty impressive credentials. Another wonderful Trinity alum. So I'm going to turn this over to him in a minute, but I want to remind you at the end of the lecture, we'll host a Q&A session. You'll be able to submit your questions at any time during the presentation using the Q&A tab at the bottom of your screen. And we'll summarize the questions and then I'll submit as many as I can to Dr. Rondello. So thank you, and Casey, it's all yours.
Dr. Stefl, thank you so much for such a gracious introduction. Having been a beneficiary of Trinity's education, it's a pleasure and a very genuine honor to return and contribute to the university's learning environment through this Food for Thought lecture series. We only have a little bit of time today, but in the brief period we have, I'd like to give you all a fundamental understanding of the work that we do in disaster epidemiology. I'll discuss the activities that we engage in before, during, and after a crisis, demonstrate some of the tools that we use in conducting the science of public health, show you a short video clip of epidemiologists conducting their work in the field where the rubber meets the road. And then I'm excited about this. We're going to try it. you'll have the opportunity to put your newfound disease detective skills to the task and solve a case, an outbreak that I'll present to you. You'll have the opportunity to reply to questions via text or through your web browser as we work together to decipher a mystery illness and protect the public. So that's where we're headed. And I appreciate you being here and hanging with me. Before we began several weeks ago, as part of the registration process, you were asked a few questions in advance of this lecture, and many of you were kind enough to respond. The first question that I posed to you was, when you think of the word disaster, what other three words come to mind? Well, I took your responses and I created a word cloud with the answers. The larger the font that you see, the more frequently that word was cited. As you read through this word cloud, note the ways in which these words are related, but also in the ways in which they're not. I'd like to emphasize the fact that disaster, the word disaster, disasters mean different things to different people. Some equate a disaster with a loss of life, some with natural disasters, and others with the emotions that are experienced during a crisis. I thought I'd share with you the definition that we typically use in epidemiology. And that's a disaster being an event in which the local capacity of the region affected has been overwhelmed to the point that they must receive external assistance from the outside. Many times that's what's the dividing line as to whether or not something is a disaster. Is the local area overwhelmed to the point that there's a request for national or international assistance? Also, an unforeseen or sudden event, often sudden event, that causes great damage, destruction, and human suffering. Sometimes that relates to a loss of human life. Many times it does not. But when we categorize disasters, we typically bifurcate that list into two buckets: natural disasters, which include geophysical, hydrological, climatological, meteorological, and biological disasters, and the second being anthropogenic or technological disasters. Think of those as the human-caused disasters. Now, the natural disasters are the geophysicals, are things like earthquakes, landslides, tsunamis, volcanic activity. Hydrological disasters are things like avalanches and floods. Climatological disasters would be disasters of extreme temperature, like heat waves and cold snaps, also droughts and wildfires. Meteorological disasters are those like hurricanes, typhoons, cyclone storms, then storm surges. And then biological natural disasters are those that cause disease epidemics, exactly like we're experiencing now, as well as things like insect and animal plagues. Those are the natural disasters. Like I said, bifurcated into two buckets, second bucket being the anthropogenic disasters, and those fall into two categories: the unintentional technological or anthropogenic disasters, things like industrial accidents, like the BP oil spill, or Exxon Valdez, or the Chernobyl nuclear power accident, and the intentional anthropogenic disasters, which are purposeful acts of terrorism, such as the anthrax attacks of 2001, the Oklahoma City bombing, or the sarin gas attacks in Tokyo. Of course, I always think, when I think of the anthropogenic disasters intentional, as number one on the list being the September 11th attacks on the World Trade Center. These categorizations and this definition come from the Center for Research on the Epidemiology of Disasters, or CRED, and I referenced them throughout this discussion. A second question that I asked you was, what type of disaster do you believe poses the greatest risk to you and your loved ones? You see your answers on the left-hand side of this slide. What I did is I took your responses and I categorized them into the groups that you saw on the preceding slide. You'll note that almost half of the responses indicated that they believe the greatest risk to them and their loved ones is a biological disaster. I can't help but think that is somehow related to, of course, the current pandemic that we are all experiencing. You'll see that there are almost equal amounts of technological, climatological, and meteorological disasters that were second responses. A small number said a hydrological disaster, and actually you can't even really see it, but the geophysical disaster was 0%. Actually, no one said geophysical, so you'll see it's kind of hiding there behind the label for hydrological. Now, on the right-hand side, you see the pie chart of what CRED, the Center for Research on the Epidemiology of Disasters, says is, in fact, your greatest risk, the greatest risk to you and your loved ones. And CRED's assessment is based on your likelihood of experiencing an event that meets at least one of these four criteria: 10 or more people killed, 100 or more people affected, a declaration of a state of emergency, and or a call for international assistance. There's that piece of local region overwhelmed and assistance needed from the outside. So based on those criteria, CRED says that you have a more than 50%, 54% likelihood of experiencing a meteorologic disaster, hurricanes, cyclones, storm surges. Again, note only when polled, only about 17% of folks gave that as their greatest concern. There are some similarities. The number of technological disasters and the risk of technological disasters, both intentional and unintentional, is about the same. But you see that there's a big difference in biological, right? Folks said biological, 46% said it was of greatest concern to them, when in fact, when it comes to real risk and real threats that you might experience, really it's only about a 1% likelihood of a threat. Finally, I asked you about your greatest concern when thinking about future disasters. And I read through all of your responses, which really struck me by their diversity. I chose to highlight some of those responses here, and you can see that in some cases, more than one person said essentially the same thing. That's where you see the indication 3x, 4x, and so on. As you read through these concerns, consider that the responses are quite diverse. But something struck me as I read them. I read through all of the different responses to this question, and I noted that as different as they were, that with no exception, there was one common thread, and that's that none of these concerns is inevitable. None is a foregone conclusion. None is a must. You know, if you look at some of the examples, we can invest in preparedness and education now before a disaster strikes. We can take steps, albeit incremental ones, in addressing climate change. We can elect leaders who prioritize disaster preparedness and readiness and adopt a more progressive approach to mitigation. And we can reach out to disadvantaged and underprivileged communities, the most vulnerable among us. So I thought that was noteworthy. None of the things that I read cannot be changed. Let me tell you a little bit what it's like for me to go to a cocktail party. At some point, you're wandering around and you meet new people, and inevitably you're chatting with someone and they ask the question, well, what do you do for a living? That's the moment at which I typically cringe, because I know what's about to happen because I've been through this before. Sometimes I'll just try to get by with, I'm a professor or I'm a physician, but that usually doesn't cut it, because the follow-up question is almost always, oh, really? Well, what do you teach, or what kind of doctor are you? Then I'm sort of forced into saying, well, I'm an epidemiologist. And when they give me a quizzical look, I then say, well, more accurately, I'm a disaster epidemiologist. And that's when they often, their face screws up and they say, well, what does a skin doctor have to do with disasters? I take a deep breath and then I explain, well, actually, epidemiologists are those doctors that specialize in epidemics and spread of infectious diseases across mass populations. And as a disaster epidemiologist, I don't only deal with emerging infections, I deal with natural disasters, I deal with technological disasters, and also acts of terrorism. And that's the point at which they usually take their drink, politely excuse themselves, take a few steps back, and they go mingle with other guests. But that is what epidemiology is. And as a disaster epidemiologist, it's what I do day to day. Disaster epidemiology is a quantitative study of distribution and determinants of health-related events in human populations. And as a disaster epidemiologist, these events occur in disasters. Now, why does this matter? This matters because of the axiom we believe that adverse health outcomes occur in, and this is key, predictable patterns. Because of that, it allows us via epidemiology to assess the short and long-term adverse health consequences from a disaster so that we can best predict and hopefully prevent them. Okay, epidemiology is the quantitative, evidence-based, data-driven science of public health. And it can be applied to disaster conditions so that we can ultimately mitigate their consequences. That's the bottom line nutshell of why it is we do what we do. Disaster epi provides what we call in emergency management situational awareness. That's information that's key and allows responders to understand what a crisis's needs are, to be able to plan their response, and so that they can gather the appropriate resources to ensure whatever they are, whether it's money, personnel, pharmaceuticals, medical material, that it's in the right place at the right time. Next, I'd like to speak a bit about what specifically we do before, during, and after disasters. Before a disaster, epidemiologists have a lot of work. In fact, arguably, this is when we do most of our work, is before a disaster even strikes. We begin by delineating at-risk populations through a process called a vulnerability analysis, identifying what people, property, and environment are most vulnerable to a given hazard. We're assessing a community's level of emergency preparedness. Now, I mentioned that epidemiology is a quantitative science, and so it necessitates data, lots of data, to use in making informed evidence-based decisions and recommendations. Now, we can get that data in a disaster by creating surveillance systems that gather information that we need. However, even in non-disaster times, there are surveillance systems gathering information all the time. Think ambulance logs and hospital records and emergency department registrar information. Oftentimes before a disaster, we're looking at those existing surveillance systems to see, do they have value? Can we adapt them? Are they flexible enough to provide us with the information that we need come disaster time when we're in the midst of a crisis and we need information to base decisions off of? Before disasters, we're educating at-risk personnel, and we're also conducting training of disaster responders, health and safety folks. Then during a disaster, once the disaster occurs, epidemiologists are among the first boots on the ground the minute that it's safe to go into a disaster zone. We're conducting a damage assessment, a rapid health assessment it's called, in order to best determine what needs are so that we can match the available resources with the most critical and most dire emergency needs of the community. Oftentimes, the epidemiologists, we are not the decision makers. I'll give you a very timely example. Mask mandates. Epidemiologists do not enact mask mandates. Politicians do, but politicians are advised by, among many others, epidemiologists that they rely on to provide them with the best possible action in a given situation. So a lot of what we do is coordinating with the decision makers. Those are actually going to pull the trigger on those mitigation and response actions that are most called for given a particular disaster's evolution. So we're working with the decision makers. We're doing a lot with media as well in communicating a message. And remember that the fundamental axiom of disaster epidemiology is that adverse health outcomes occur in predictable patterns. Because of that, based on both our understanding of the current disaster to date and based on historical precedent and our study of previous disasters, we can advise with relative accuracy what the probable health effects are going to be for a given disaster well before the data is even collected for that disaster. In fact, I don't want to turn this into a lecture about COVID-19, which, as you might imagine, has been all-consuming for me for a year and a half. But I'll tell you that the trajectory of this pandemic was largely, completely predicted in terms of the peaks and the valleys, the waves, and how this was going to play out by epidemiologists, almost to the week of accuracy. We're not Nostradamus, we're not miracle workers. We're able to do that because of our understanding of historical precedent. This is not the first epidemic to occur in the world, okay? And based on whatever limited information became available at the time, and now we're understanding of filtering that information and deciphering it in the context of what we know to historically be true. After a disaster, epidemiologists are conducting a retrospective analysis, looking at the information that was gathered and trying to learn from that experience so that we can apply that knowledge in a structured way to future disasters. What was most effective in mitigating mortality and morbidity? Why did some die and others survive? This is also the period during which we will assist in long-term rehabilitation and health services reconstruction. While during the disaster, it might have been a priority simply to keep the ER open or open a single runway in a flooded airport, or establish basic single line telephone communications between operations centers. While that may have been during the disaster, now that we're after the disaster, we're trying to do the long-term rehabilitation and reconstruction. And I like to think of that as restoring the community to where it was before the disaster even occurred. This is also the period during which we will conduct our lessons learned and try to garner as much as we can from the experience so that we can build upon the foundation of knowledge of disaster epidemiology to assist us in our future inevitable responses. Now, I've spelled this out in 3 slides and made it sound like it goes absolutely swimmingly with every single disaster. I've consolidated what is decades of work into a few PowerPoint slides. Suffice it to say, it rarely goes that smoothly. There are innumerable challenges, problems, and limitations that we must deal with on a day-to-day basis when mitigating a crisis. It's difficult to get good data on a normal day. Now imagine having to gather the information that you need to make critical life and death decisions in the midst of a crisis where there's no power, where there are roads closed, where there is limited communication, okay? It only makes it excessively more difficult to get the information that we need. That forces us to rely on secondary, less accurate sources of information. Being a physician and dealing with clinicians all the time in my job, I understand why it may seem as if the accumulation of this information is a low priority. Because, as physicians, as healthcare practitioners, we are trained to put blinders on and to focus on the patient in front of us and to do the maximum amount of good for that patient at that time. And so that's where it's deeply ingrained in our DNA as practitioners. That's where our attention and our energy is focused. And the idea of completing reports that log how many patients you've seen, common patterns in symptomology, may seem extraneous. Unfortunately, that's not the case. In fact, that's completely contrary thinking to what the priorities are for public health officials that have their eyes focused on the big picture, that are trying to handle this disaster from a global perspective. And so a big challenge is getting the frontline healthcare personnel to understand why it's so critical that they assist us in our efforts if we're ever going to dig ourselves out of this hole that we're in. Data is perishable. From the time it's collected, the value of it begins to decrease. And the longer it goes from the time the information is gathered until the time you act on it, the less appropriate that action is. Again, in disasters, data is spoiling all the time. And because of communications and access and logistical and administrative and other challenges, unfortunately, you don't get that data stream that you would ideally have in a non-disaster condition. I mentioned politics, right? What could possibly go wrong with politics? Oftentimes, what we are recommending as the best action from a medical public health perspective is not appealing to the individual that has to pull the trigger and enact what we are, saying is the best course of action. And so we often have to deal with managing that conflict. Lack of time, difficult follow-up. I hope you're getting the idea that there are lots of opportunities for the waters to get muddied very, very quickly. Now, one of the primary tools that we use in epidemiology that you may not have ever heard about until COVID-19 was the epidemic curve. Epidemic curves are a tool that we use all the time when investigating an outbreak. And you've probably seen various iterations of epidemic curves in the media related to the current pandemic. Epidemic curves show us an outbreak over the course of time. Typically, the x-axis is some function of time, like days, weeks, or months. And typically, the y-axis is number of cases, number of persons sick, say. By continually assessing the epidemic curve and monitoring its direction, its shape, its trajectory, we can conduct a continuous, ongoing assessment of the disaster condition. Epidemic curves can tell us lots of things. It can tell us the size of an outbreak, how big it is, what's its magnitude, how many people are ill, what the trend of the outbreak is. Are we at the beginning of this, or are we at the middle? Did we hit the highest point yet? Is this still growing? The spread of the outbreak. Is there a pattern to this curve that we can discern over time? How is the outbreak being spread? I'll show you in a minute that the epidemic curve may actually help to inform how the infectious agent is passing from person to person to person. And then, of course, the period of exposure. When did we first see symptoms start to appear? And when was the last case of symptoms reported? So here's an example of 3 different epidemic curves and the lessons that they tell us. The first on top is a point source epidemic. When we see an epidemic curve of this shape, it tells us that there was contact with the source by multiple people over a short window of time. You'll note that the epidemic curve has a rapid rise and then a relatively slow fall. This indicates that most cases were onset at the same time from likely the same source. A good example of a point source epidemic would be something like the spoiled potato salad at a church picnic. I'll tell you that if you ever go to epidemiology school, you're going to hear all about potato salad and church picnics. I don't think I could ever go to any outdoor function and even touch the potato salad after a lifetime of epidemiology education. That's a very common example. Don't touch the potato salad. Second is a continuous common source epidemic. you'll note that there was contact with the source, but rather than occurring in a short period of time, the contact occurred over a protracted period, a long period. There was a slow increase, and then possibly a plateau, and then a slow decrease, okay? As many different people were exposed to the common source, but over a long period of time. A good example of this would be something like a poisoned well, in which people are periodically accessing water from the well, single source, but over a period of time. The third graph demonstrates an epidemic curve for a propagated outbreak. When we see this shape, it indicates to us that there was no common source. Okay, what you're seeing is successive peaks, and then a wave, and then a decrease, and then another peak, and then a decrease, and so on. You'll see tall peaks for each incubation period of the infectious agent as it's transmitted from person to person to person. I can think of a very timely example of a propagated outbreak epidemic curve, right? When I mentioned that we public health professionals have largely been able to describe and predict the evolution of the COVID-19 pandemic, this is what I'm talking about. It's because we are able to interpret and decipher the code that's embedded in the epidemic curve, and it tells us about wave one. And then we knew that there was going to be a decrease in the summer in some parts of the country, but an increase in others, and so on and so on and so on. You're all very well aware of how COVID-19 has played out. I next want to give myself a few minutes break of talking, and I'd like to show you a short video clip. I want you to see what epidemiology looks like in action. I want you to get an example of disaster epidemiologists working in the field doing what we do. And probably the best example that I can think of to give you is the EIS, the CDC's Epidemic Intelligence Service.
If a disease breaks out anywhere in the world, the Epidemic Intelligence Service, or EIS, is called in to investigate the outbreak.
A lot of people refer to EIS as the disease detectives because we are the ones sent out during outbreak or emergency response situations.
The elite team works quickly to figure out who is sick, the origin of the infection, and how to stop it from spreading.
I'm Caitlin Casaboom. I'm a second-year Epidemic Intelligence Service officer at the U.S. Centers for Disease Control and Prevention. My first outbreak was an anthrax outbreak in wildlife in Namibia. Over 200 hippos and Cape buffalo died. Over 1,000 people were exposed to the carcasses. We assisted Namibia with control efforts in order to prevent future infections.
Today, Caitlin has been deployed here, on St. Croix in the U.S. Virgin Islands. In September 2017, the islands were hit by 2 major hurricanes. In the aftermath, several people fell sick to a bacterial disease called leptospirosis, the first time it was seen on the islands. The local health department needed backup, so they called in the disease detectives.
Leptospirosis, or lepto, is a bacterial disease spread through the urine of infected animals. If there's flooding or rain, humans could have contact with water that has been contaminated. The symptoms of lepto are flu-like illness, but people that get a very serious infection, it can be fatal. We have 14 people from CDC that are down here for this, as well as at least 25 local volunteers. We're gonna go back to the block that we were in yesterday. So it'll be pretty quick.
Once the team has their map assignments, the detective work begins.
We start going door to door with the primary goal of educating people on the disease. Hi. Hi, good afternoon.
Hi.
Hi, nice to meet you.
I'm Mike.
We asked them if they would be willing to take a survey. We take a small amount of blood so that we can test and see if they've been exposed to lepto. The lab takes a specimen, they'll centrifuge or spin down the specimens, and then they'll store those for freezing to be eventually mailed back to CDC in Atlanta for the testing. What we're really hoping is that the Department of Health can use that information when paired with the survey data to identify risk factors for exposures. I have a training in animal diseases, and being able to apply that to help humans is kind of the best of both worlds. You're doing something that is actively preventing people from getting sick with really serious diseases. Being out there and doing that and interacting with people and, making that difference, it's been a great experience.
All righty. So now it's your turn. You will play disaster epidemiologist and be your own disease detective. I created a case that was adapted from the CDC's Solve the Outbreak educational series. And what I'd like to do is give you this case to consider, throughout which there will be several questions that I'll ask you to respond to. You can respond to those questions either by your cell phone, by texting the number that'll appear on the screen, or if you have access to a computer or a tablet, you can go to a web browser and respond to the questions as well. So without further ado, put on your detective hat and consider what I'm calling the case of maybe yes, maybe no. In this case, many students at a university in Texas haven't been able to keep down their lunch for the last 2 days. They've stopped showing up for their fall midterm exams, and instead, they're now showing up at the Student Health Center. Here's your first clue. A couple of students are feeling miserable after partying and eating pizza following a big football game. And 2 students show up at the Student Health Center asking if they can get an excuse note so they don't have to take their midterm exams. Now, the nurses at the Student Health Center don't think much of this, but then more students start showing up with vomiting and diarrhea. And before you know it, dozens of students are now sick, and the staff at the health center begin to suspect that there is some kind of stomach bug going around. Remember that epidemiology is a quantitative, data-driven science. And so you start collecting data. Over the last 2 days, 53 students now have come to the Student Health Center with similar symptoms, all of which had sudden onset. The medical staff tells you that they've diagnosed these students with acute gastroenteritis, but they've been unable to nail down a specific cause. So you speak to the 53 students and you notice that there are some trends in the symptoms that they are experiencing. And you gather that data and you plot it out, and I've presented that to you on the right-hand side of your screen. These are the most common symptoms experienced by the 53 students. So you see that almost all of them, 91%, are experiencing vomiting, just as many almost experiencing nausea. You've got a good amount of diarrhea and stomach cramps, 61% fever, and about half of them have a headache. I mentioned the students were diagnosed by the practitioner in Student Health Services as having acute gastroenteritis. So let me say a few words about that. Acute gastroenteritis is an inflammation of the stomach and the intestines, and most people with acute gastroenteritis experience watery diarrhea, vomiting, headache, fever, stomach cramps. These symptoms typically resolve on their own after a few days, in most cases. And most often with acute gastroenteritis, viruses are the most frequent cause, although not necessarily. Also bacteria, parasites, and even exposure to certain chemicals can be the causative agent. So here's your first chance to play disaster epidemiologist. What should you do next? To respond to this question, I ask you to, again, either text Casey Rondello 125 to the number 37607. And then once you've joined, click on A, B, or C to respond. Alternatively, you can go to a web browser and type pollev.com/Casey Rondello, follow the prompts, and you will provide your response there. So I'll give you 15 seconds for those who are able to respond to the question. So far, it's looking like a runaway with letter C, but let's see if there are any other responses. I haven't yet figured out how to get the Jeopardy theme to go through the PowerPoint, but perhaps in subsequent lectures, I'll get that Jeopardy theme playing. All right, so your options are A, tell the 6 students to stop partying so hard and go to class. B, keep the 6 students in the same area until their symptoms are gone. Or C, find out if others are sick as well. Well, no one's picked letter A, tell the students to stop partying so hard and go to class, and that's good. Because even though the temptation is to think that they just partied a little too hard, one of the symptoms that was pretty frequent, 61% experienced fever, along with the vomiting and the nausea. And so that gives us a clue that there's something else going on here. At this point, there is no need to keep the students away from others until symptoms are gone. We only have very preliminary information. And frankly, putting 53 students in the same area for more than a few hours is probably going to drive you crazy as well. So the next step is to determine how widespread this is. Find out if others are sick too. And guess what? It turns out they are. Things are getting worse. Now there are 76 students with similar symptoms over the last few days. And the good news is that most students are getting better in a day or two. However, a few students have become so severely dehydrated that they necessitate treatment at a local hospital. Stool samples are taken from the sick, and parasitic and bacterial testing is performed. Unfortunately, the results come back and they're negative for the most common infectious bacteria and parasites that could cause this. And so that hasn't provided much help for us. We take those stool samples and we forward them to the health department lab for viral testing. Let's collect some more data. To find out what caused this outbreak, you need to know when it started. And so we are going to construct a simple epidemic curve. Looks like the first students got sick on March 9th, and that the epidemic peaked on March 10th when we got 42 people sick. The last person to experience symptoms reported their symptoms on March 12th. We can tell that from the epidemic curve. Now, if you remember a few slides ago, this picture of this curve is characteristic of a point source outbreak. And so that's the direction that we are leaning toward, okay? We know historically, remember epidemiology is, or disaster epi is often informed by historical precedent. We know that symptoms from a typical stomach virus usually start a day or two after contact with the causative agent. And so based on that and this epidemic curve, you suspect that the first person was likely exposed around March 8th, okay? And the exposure period you calculate to be between March 7th and 10th. So that's the time from when the students were likely exposed to whatever the contaminant is. Now remember that these students were diagnosed with acute gastroenteritis. And the best way to deal with acute gastroenteritis is to stay hydrated. You do that by drinking plenty of clear liquids like water or sports drinks. You certainly don't touch drinks with alcohol or caffeine. You might eat ice chips and frozen pops. And for those that are most severely affected, if you're so weak that you can't hold a cup, you want to hydrate using a squeeze bottle or a container with a straw. Okay, disaster epidemiologists, second question. What's next? Your options are talk to the students and determine what they might have in common that made them sick, shut down the dorms and send all the students home, or tell the students not to eat or drink anything for the next 24 hours. Those are your choices. Talk to the students and look for common things that might have gotten them sick, shut down the dorms and send all the students home, or tell the students not to eat or drink anything for the next 24 hours. All right, looks like we're on a roll. Your answers are correct, okay? We need to find out what these students have in common. Did they go to the same party? Did they go to the same place? Did they eat the same foods? Did they live in the same dorm? We don't know the answers to those questions. At this point, it's premature to shut down the dorms. We know that this is an illness that, while it's not a whole lot of fun, that it's short-lived and resolves on its own after a few days in almost all cases. And the last thing we want to do is tell students not to eat or drink anything for the next 24 hours. We just talked about the importance of replacing the fluids you've lost from vomiting and diarrhea by ingesting copious amounts of clear fluids. Guess what? Great news. The outbreak seems to be slowing down. Over the last 3 days, there haven't been any additional cases, and those that are sick, their health is improving. That's the good news. The bad news is we still don't know what caused the outbreak. And so we're going to interview students, and we're going to look for patterns in the data that help us find the source and stop any further spread. The 76 students that you've identified have some commonalities that occurred during the exposure period, which you already determined was March 7th to 10th. All of the students live on campus in one of the university's 4 dorms. All of the students drank tap water from those dorm buildings. All the students ate in the school's food court, and the food court is one of 3 different eateries on campus. And only a handful of 6 students have classes in the same building. So if you look at the pie charts, you'll see there's a breakdown between male and female, between class year, freshmen, sophomores, juniors, and seniors. In the residence halls, they're all dorm students, but they come from those 4 residence halls, and you'll see where they ate from. Okay? All right, disease detectives, where did this outbreak start? Was it the water supply in the dorms? Was it the classrooms? Or was it the food court? Now, I guess theoretically, it could be started via the water supply to the dorms. But if that were the case, many more students and people in the community would be sick. You know, the water supply to the dorms doesn't just go to the dorms. It likely goes to other buildings on campus, and more likely to other places in the city or the community where this is. And so if it were the water supply to the dorms, chances are we would see more widespread illness. It's not the classrooms, because only a few of the students shared the same classes. And so it looks like we're pointing in the direction of the food court. And that's because all the 6 students ate at the food court during the time that they were most likely exposed. Furthermore, the food court is one of 3 eateries on campus, and it would be unusual for all 76 cases to have eaten at the same location and it not be the cause of the outbreak. And so you suspect that the outbreak started at the food court, but you don't know that for sure. So you need to confirm your suspicions. One way to do that is to interview students on campus who are not sick. We'll call those folks controls. And you talk to 273 controls who don't have any symptoms. Most of those folks, that 273, did not eat at the food court between the 7th and the 10th. They ate somewhere else on campus. But 100 of the 273 who are not sick did eat at the food court during this time. You need to identify the source of the exposure. And so you ask students about what they ate when they were at the food court. You also send your colleague to interview the staff who work there. Of the 76 sick students, they've been sick a few days ago now, you're able to track down 62 of them. You interview the 100 student controls, who are the ones that ate at the food court but did not get ill. And you ask all students, sick and not sick, to list the foods they ate at the food court during the days in question. The food court's got a sandwich line, salad bar, a grill, a soup line, and a pizza counter. And you use the data from your interviews to calculate an attack rate. An attack rate is simply a percentage of the number who ate the food item and are sick divided by the total number who ate the food item. And you'll see here that we have data representing the attack rate for all 5 areas of the food court for both the people who ate at the food court and the people who did not eat at the food court. Note the attack rates. And you can see that our biggest clue is that most of the sick students ate sandwiches, right? Attack rate 78%. Most of the sick students ate sandwiches. Most of the well students ate foods from the salad bar grill, soup line, or pizza counter. So we're going to concentrate on those that went to the sandwich line. Our next step is to calculate the attack rate of the foods from the sandwich line to find out what is causing the students to get sick. Okay? And I want you to very carefully look at these attack rates. We're going to try to find the culprit in the sandwich line. I'll give you a hint. To identify the most likely source of the outbreak, you're looking for 2 things. You're looking for a high attack rate among those who ate a specific food, while simultaneously a low attack rate among those who did not eat the food. So we have these items that are on offer at the sandwich line. We've got cheese, we've got mayo, we've got ham, turkey, and mustard. Again, we're looking for a high attack rate among those who ate a specific food, but a low attack rate among those who did not eat this food. Okay, take a look at this data and tell me, based on this information, what's causing the students to get sick. You have 3 choices. Is it the ham, the cheese, or more than one of these items from the sandwich line? Okay, do you blame the ham, the cheese, or more than one item from the sandwich line? All right, well, we look at that data, and if you look at the information for ham, and I'll go back, look for the information for ham, certainly some of the students who ate the ham are sick, but we need to compare that to other information, other attack rates. If you look at the cheese, same sort of thing, right? There certainly was a high attack rate among those who ate the cheese, low attack rate among those who did not eat the cheese, but we can't consider that in isolation. We also have to look at some of the other items. And so the correct answer is there are actually several items that are causing students who ate at the sandwich line to get sick. Remember, your colleague is also interviewing the food court workers. And one of them interviews Helen. Her job is to make the sandwiches. And she says that she wasn't feeling well and had diarrhea and stomach cramps a few days before the outbreak began. Oh, Helen. You notice that she frequently touches other surfaces and then continues handling food without washing. You also note there really are no signs posted anywhere reminding people about the importance of hand hygiene. You get back to your office and the results are in. The health department calls and tells you that the samples you sent them were positive for norovirus. And putting 2 and 2 together, you suspect that the sick food court worker spread the virus when she was sick with diarrhea and handled the foods in the sandwich line. What is norovirus? It's a very communicable viral illness. Someone's infected by eating foods or drinking liquids that are contaminated with the pathogen, or touching contaminated surfaces and then putting their hands to their eyes, their nose, their mouth. Also, you can get norovirus from close contact with someone who's infected. The symptoms are similar to what we experienced in this case, as is the timeline in which people improve. To help prevent norovirus infection, hand hygiene is key, as is proper food preparation. Rinsing fruits and vegetables, cooking seafood properly. If you are ill yourself, don't cook food for other people, avoiding touching ready-to-eat foods with bare hands, and then cleaning and disinfecting surfaces are key. Disease detectives, you're not off the hook yet. One final question. We don't want this to happen again, so What should you do to prevent another outbreak like this in the future? Educate the food court workers to avoid preparing food while sick. Reinforce the need to properly wash hands before preparing food. Require all food staff to submit lab work every week to ensure they are not infected, or all of the above. The famous question or the famous answer that we all love to see on an exam because we debate and debate and debate, all of the above. Well, as a public health person, you're probably going to say he's never going to recommend that we don't have people wash their hands. Educating food court workers, certainly important. Requiring people to submit blood work, not in this case, right? Norovirus testing isn't widely available. Tests are positive long after you're contagious, and people should not handle food for some period of time, 3 days or so after they're ill. So in this case, the answer is A and B. That's it. I know you're probably wondering what the rest of the story is. This is an outbreak that is fictional, but was based on a real outbreak that occurred at a Texas university in 1998. I'm happy to say that while I won't tell you what university is, it was not Trinity. Epidemiologists and scientists worked very closely with the health department and in coming up with the solution to this case. And of course, the best course of action to prevent this from occurring in the future is educating workers, reinforcing hand hygiene, and having good symptom reporting policies. I want to leave you with a quote that I often turn to when giving lectures about disaster epi. And it's a quote from JFK, who, as you know, handled more than his fair share of disasters and crises. He said that when written in Chinese, the word crisis is composed of two characters. One represents danger, the other represents opportunity. Now, I was a visiting scholar in China a few years ago, and I actually asked about this. Turns out this is an oversimplification of the translation, but I certainly appreciate the sentiment. Times of crisis need not result in disaster. While they certainly pose a threat, they also do provide us with an opportunity to come together, an opportunity to be resilient, and an opportunity to emerge better and stronger than we were before. That's all for me. We may have a few minutes for questions, but I wanted to leave you with my contact information. You can easily reach me at rondello@adelphi.edu. I'm so grateful I had this opportunity to share with you a glimpse into what my world is like, particularly in the midst of the COVID-19 crisis. I urge you to continue to support this work yourself by prioritizing disaster preparedness in your own lives, particularly when we're not in the midst of a crisis. And of course, I sincerely wish you and your loved ones well for the remainder of this pandemic and beyond. Thanks for having me.
Okay, Dr. Rondello, thank you so much for that very thoughtful and engaging presentation. We have time for maybe 2 questions, and I'll try to summarize what we've got in the chat room. I think we'd like you to comment a little bit further on the current COVID situation. Most of the disasters that you've dealt with are time-bound, a flood, some kind of destruction, a storm, but this one is clearly prolonged. What does that bode for the future? What kinds of research will you be doing on the long haulers, the after effects of this disease? And so if you just say a few words, please.
Sure, so I'll talk just a bit about the trajectory of the pandemic. We are coming to the end of what we expected to see, variant-driven sawtooth pattern to the epidemic curve, now going into the summer, where there's going to be a vast improvement, a decrease in cases, both because of the factors that are making it harder for COVID to spread, like people spending more time outdoors, warmer climates around the country, but also because vaccine coverage is substantially building throughout most communities in the United States. That doesn't mean COVID's going away this summer. There will be a small resurgence in the fall and the winter. We hope it's not a big resurgence. Time will tell. And COVID is something that we will continue to face as a disease for, a long time to come. That doesn't mean the pandemic is going to continue for a long time. Just like H1N1, SARS, MERS, Zika, these are diseases that still exist, and people still get sick from them. But the pandemics they caused are long over because we now have mitigation strategies in place in order to keep that disease from spreading widely and hold it in check. So that's what I see for the future of COVID-19. The immediate term, things getting better through the summer, there being some level of resurgence in the cooler climate of the fall and the winter, but then the pandemic phase of COVID being over and it just being another pathogen that we deal with like the others.
Okay. Thank you. You have so much experience, both domestically and internationally. What's the most cogent or terrifying or difficult, challenging situation that you have experienced?
That's a tough question. You know, I think that the acts of terrorism likely top that list. And it's not because of the excess amount of morbidity and mortality they cause, because in many cases, the acts of terrorism actually have, when you look at morbidity and mortality figures, much lower numbers than some of the other types of disasters like a hurricane or an earthquake. It's because of the psychology behind a terrorist attack. It's because of the uncertainty, the questioning it causes of people being uncertain about their faith in their community, in the people that respond, in whatever they believe is a higher power, you know, all of those factors. I'd say that's certainly one. And the biologics are definitely up there as well, like what we're experiencing here. When you talk about other natural disasters, they don't have the longevity. And while they can be catastrophic and cause widespread destruction, as you said, they're time limited. And so you don't have to worry about their perpetual continuation, their propagation through time. That you get with, not with the chemical disasters, the radiological disasters, but certainly with the biologic ones.
Well, thank you. We could go on, I'm sure, but we're out of time. Again, thank you so much for your thoughtful lecture and for your comments. One of the things we didn't mention is that Dr. Rondello has recently been named University Epidemiologist at Adelphi, which is a real honor. So I hope everyone enjoyed this evening's presentation. And for more information on future podcasts, check trinity.edu/alumni. Thank you so much for joining us. Thank you, Dr. Rondello. You make Trinity proud. And on behalf of all Tigers, have a good night.